Welcome, everyone. We're diving deep today, specifically into treatment of Meibomian Gland Dysfunction, a synopsis of all the latest MGD research from international journals. And it's all compiled by, well, you know him, the renowned eye surgeon, Professor Dr. Suhail Sarwar. This one's going to be pretty technical, using the terminology we use every day in practice, so it's definitely geared towards us, ophthalmologists. For anyone who's not an ophthalmologist and wants to learn more about eye diseases, Professor Sarwar actually has a podcast series that's perfect for you. It's in his playlist of podcasts for the public. All right, so let's get into it. Let's dive into the advanced science and treatment options for MGD.
Yeah, it's really an impressive collection of studies. I think what stands out to me is how it highlights the crucial role MGD plays in so many different eye conditions. It really goes beyond just the typical dry eye discussion.
Okay, I like that. Let's unpack that a bit. So we know that MGD is a leading cause of evaporative dry eye disease. It affects tear film stability and ocular surface health. But these studies really emphasize its role as this underlying factor in other conditions that sometimes seem completely unrelated.
Exactly. Like there's this new study on thyroid eye disease, right? And they were looking at patients with mild versus moderate to severe TED. What they found was that in those moderate to severe cases, MGD was the primary contributor to dry eye, even when their tube production seemed normal.
Wow, so it's not always as simple as just looking at tear quantity.
No, not at all. It's about the quality of those tears, too, that lipid layer and how MGD messes with it. And that can lead to a whole bunch of issues. There's another study that looked at MGD in patients with diabetes. And what they found was a much higher prevalence and severity of Meibomian gland dropout and dysfunction in those patients compared to people without diabetes. It seems that those tiny blood vessel changes that happen with diabetes might actually be affecting the Meibomian glands as well.
So we're potentially seeing this link between systemic conditions like diabetes and how MG develops and how severe it gets. It makes you think about all the other systemic conditions that could be playing a role.
Yeah, for sure. And that's why research like this is so important. It's helping us understand these connections so we can really fine-tune our treatments. Which brings us to one of the most talked about treatments for MGD these days, intense pulsed light therapy, or as we all know it, IPL.
Yeah, IPL has become this potential game changer. But I think rather than just listing all the studies, maybe you could walk us through what makes it so promising, like what's actually happening when we use IPL.
Sure. So IPL really tackles the problem from several different angles. It fights inflammation, which is a huge driver of MGD, both directly and indirectly. So the light energy from IPL, it actually targets and destroys those superficial blood vessels that are contributing to the inflammation. It also changes the whole inflammatory process, reducing those pro-inflammatory cytokines. And on top of all that, it improves both the quality and the quantity of meibum, helping to restore that important lipid layer.
So it's kind of like this multi-pronged attack on MGD.
Yeah, that's a great way to put it. But like with any treatment, we're always trying to figure out how to make it even better, right? There's been this debate about combining IPL with topical steroids.
Right.
But there's a recent study, and it found that using steroids long-term didn't actually make the IPL any more effective.
Really?
Yeah. So if IPL is that powerful on its own, it makes you think about how this might change our treatment plans going forward. Like, are there any concerns we should keep in mind or things we should be looking out for?
It's a good question. I think this study really challenges that automatic idea of just adding steroids to everything. It suggests that IPL could be enough by itself, which would be huge for reducing steroid dependence and avoiding those potential side effects.
For sure. And it also brings up another interesting question. What's the best way to actually apply IPL, directly or indirectly?
Yes. The great debate.
There was a study comparing the two methods, and they found that both improved Meibomian gland function, but only when they applied the IPL directly, with the light source closer to the eyelid margin, did they see improvements in things like corneal fluorescein staining and Meibomian gland morphology.
So it seems like how far away that light source is really matters if we want to see those objective changes.
Yeah, it does. And this is where understanding all the nuances of the research can really help us in our practice. Like I said, both the direct and indirect methods led to big improvements in how patients felt, their subjective symptoms. They measured that using the SPEED questionnaire.
Which is super important, right? At the end of the day, we want our patients to feel better. And this suggests that both methods can help with that.
Definitely. It's a reminder that we need to think about both those objective measurements and what our patients are actually experiencing when we're deciding on the best way to use IPL.
That makes a lot of sense. Now, IPL is obviously showing a lot of promise, but Professor Sarwar's synopsis also looks at some other really cool alternative treatments. One that caught my eye was the liposomal drug delivery systems.
Oh yeah, those are fascinating. Imagine being able to deliver medication directly to the meibomian glands using these tiny little lipid-based vesicles.
It seems so precise.
Ah.
But is there any research showing that it actually works?
There is. There's a study where they looked at curcumin-loaded liposomes in rabbits with MGD and dry eye, and they found that these liposomes were able to improve tear film stability and reduce inflammation on the surface of the eye.
Wait, curcumin, like the spice turmeric. I know that has anti-inflammatory properties.
Exactly. And what's even more interesting is that these curcumin-loaded liposomes, they were just as effective as liposomes containing cyclosporine A. You know, the medication we already use all the time for dry eye.
So there could be a plant-based alternative out there. That could be a really good option for patients who don't do well with cyclosporine or who are worried about using it long-term. But I'd want to know more about how safe these curcumin liposomes are and what the long-term effects are like. Have there been studies on that?
Those are great questions, and that's definitely an area where we need more research. It's promising, but we need more data before it becomes a go-to treatment, and that's something Professor Sarwar really emphasizes throughout his work. We need more research to make sure these new approaches are safe and effective.
Absolutely. Science is always evolving. Now let's talk about something a little different. Oral antibiotics. There was a systematic review and meta-analysis that found that oral azithromycin could be even better than oral doxycycline for reducing MGD symptoms. How do those findings fit in with how we usually treat MGD? Is this going to change our go-to antibiotic?
It's interesting, right? It challenges what we've always done, using doxycycline first, but we have to remember that this was a meta-analysis, and the quality of the studies they included can be different. So we really need some large, well-designed, randomized controlled trials to back up these findings. And those trials need to figure out the best dose and how long we should be using azithromycin for.
So it's not time to throw out our doxycycline prescriptions just yet, but it's definitely something to keep an eye on.
Exactly. And it highlights how important it is to be critical of research. We can't just accept something as fact based on one study.
Agreed. Now, another interesting connection that Professor Sarwar pointed out is this potential link between Demodex and MGD, especially when it comes to recurrent corneal erosion syndrome.
Yes, that's an area that's getting a lot of attention these days. One study found that patients with RCES had way more Demodex mites and more severe MGD than the control group.
So that makes you wonder if having all those Demodex mites is actually playing a role in causing RCES or at least making it worse.
It's a possibility that we should definitely be looking into. If we could target Demodex, maybe we could stop that cycle of inflammation and erosion and get better outcomes for these patients. There are already studies going on looking at different ways to treat Demodex, things like tea tree oil, topical metronidazole, and even IPL. It's a really exciting area of research that could really change how we treat our CES.
That's great to hear. Now, Professor Sarwar also gets into how tear film dynamics and meibomian gland function are all tied together.
Right. And this is where you really start to see how everything in the eye is connected. Like there's a study on patients with facial palsy that showed they had a lower tear meniscus height and their tears broke up faster, both when they blinked and when they didn't. It's most likely because the Rieland's muscle, which normally helps empty the meibomian glands when we blink, is weaker in those patients. So the way we blink, how well our muscles are working, it all affects meibomian gland health and tear film stability.
That's a perfect example of how all these different parts of the eye have to work together to keep the ocular surface healthy.
Exactly. It shows us why we need to think about the bigger picture when we're looking at and treating MGD. We can't just focus on the glands themselves. We have to think about tear film dynamics, how the eyelid is functioning, and the patient's overall health.
It's all about seeing the whole picture.
And that holistic approach is definitely reflected in the research, too. There's a study that looked at how high blood sugar affects tear film and meibomian gland function. They found that people with high blood glucose had worse dry eye symptoms, a lower tear meniscus height, faster tear breakup time, and even more redness in the white part of their eyes.
So again, we're seeing how a systemic condition like diabetes can directly impact ocular surface health.
Exactly. And that reminds us that managing blood sugar isn't just important for the body in general, it's important for the eyes too.
It's been really eye-opening, no pun intended, to see how MGD, tear film dynamics, and systemic factors are all intertwined. Professor Sarwar has really done a great job bringing together all this cutting-edge research. But before we go on to the next part of our discussion, Let's take a minute to think about what we've learned so far. What are some of the key takeaways that stand out to you? And how do you think this new research is going to affect what we do in our practice?
Well, I think one of the most important things we've learned is that MGD is way more common and has a much bigger impact than we may have thought before. It's not just a minor annoyance. It can seriously affect people's lives and contribute to a whole host of other eye problems. So we really need to be catching it early and treating it aggressively.
I completely agree. And I think we're starting to get a much better understanding of the complex inflammatory processes that are happening in MGD. That's opening the door to new targeted therapies, like those liposomal drug delivery systems we were talking about.
Definitely. And let's not forget about the potential role of Demodex in certain types of MGD, especially RCES. Managing Demodex might actually become a routine part of how we treat these patients.
These are all really valuable insights. We've covered a lot already, but there's still so much more to discuss. We'll be back in a bit to delve into the next set of studies and talk about where we think MGD treatment is headed in the future.
It really is amazing, the more we dig into this research, the more we see how interconnected everything is in the eye.
It's true. It's not just the Meibomian glands themselves, it's how they work with the tear film, the eyelids, even things going on in the rest of the body.
Right, exactly. Like that research on tear film composition, for example. One study looked at postmenopausal women with primary acquired nasolacrimal duct obstruction, so PANDO.
Okay, help me out here. Why focus on this specific group of patients?
Well, because we know that having PANDO can change the makeup of the tear film, which can then contribute to dry eye. So they wanted to see how those changes were interacting with MGD.
That makes sense. So what did they find?
They found that the patients who had both PANDO and obstructive MGD, they had a lot more of these pro-inflammatory cytokines compared to the patients without OMGD.
So it's like a double whammy of inflammation. You've got the blocked tear duct and the Meibomian gland dysfunction, both causing more inflammation in the eye.
Exactly. And these particular cytokines, IL-8, IL-1 alpha, IL-1 beta, and MIP-1 alpha, they could be targets for new treatments in the future. Like if we can figure out a way to reduce that inflammatory response, we might be able to manage both PANDO and OMGD better.
It's definitely a promising area for more research. We need to figure out exactly how those inflammatory pathways work so we can develop really targeted therapies.
Right. And this study also found that interferon gamma was higher in the PANDO with OMGD group 2.
Okay. And what does interferon gamma do in this whole scenario?
Well, having too much interferon gamma has been linked to tear hyperosmolarity, and that's a big driver of those dry eye symptoms and the damage that happens to the ocular surface.
So it's another piece of the puzzle. It's connecting how the tear film is composed, the inflammation that's happening, and the MGD. It really shows you how important it is to look at everything when you're diagnosing and treating these patients.
I agree. We have to consider the whole picture. And that brings us back to that discussion about Demodex and MGD.
Ah, yes, the Demodex debate. Are they harmless little critters just hanging out on our eyelids? Or are they actually causing problems?
It seems like the research is pointing more and more toward them actually causing some trouble. We've already talked about how they could be linked to recurrent corneal erosion syndrome, but there's this study that really dives into the relationship between Demodex, how well the Meibomian glands are working, and whether IPL can help treat RCES.
Okay, tell me more. I'm intrigued.
So what they found was that the patients with RCES, they had a lot more Demodex mites, and their Meibomian gland scores were worse compared to the control group. But here's the interesting part. The patients who got both IPL and Meibomian gland massage, they had a big improvement in their Meibomian gland functioning. They had fewer Demodex mites.
So the IPL might actually be addressing two problems at the same time, the Meibomian gland dysfunction and the Demodex infestation.
That's what it looks like. And it's supported by the fact that the group who got IPL had fewer relapses compared to the group who just got medication. It seems like going after both the MGD and the Demodex might be a more well-rounded approach to treating RCES.
It's a really good argument for thinking about Demodex management as a standard part of our RCES treatment plan.
Yeah, I think so. And this brings us back to IPL therapy and all the research that's going on to figure out the best way to use it. We talked about direct versus indirect application and how the distance from the light source can affect the outcomes.
Right. It seemed like the direct application was better when it came to things like corneal fluorescein staining and how the glands actually lived.
Yeah, but when they looked at how much the symptoms improved, both the direct and indirect methods, whether the light source was 3 millimeters or 10 millimeters away from the lower eyelid, made a big difference in the patient's speed questionnaire scores.
So even if the direct method might be better for those objective measurements, both methods seem to help patients feel better.
Exactly. It makes you think that the benefits of IPL go beyond just that targeted area and might be affecting the whole inflammatory process that's involved in MGD.
So it's more than just the heat and light directly affecting the glands.
Right. There's definitely more going on there, and it's something we need to study more, like what happens after the IPL, how does it change the inflammatory response? Those are questions that could lead us to even better, more targeted treatments.
It's pretty amazing how much we still don't know about this treatment.
I know, right? It shows you how important it is to keep up with the research and always be questioning what we think we know.
For sure. So Professor Sarwar also included a study in his synopsis that went back to the basics. They looked at just eyelid hygiene. They compared eyelid hygiene with and without adding in a lipid supplement.
Yeah, that was a good reminder that those basic things we do can make a big difference in managing MGD.
And the results were really impressive. Both groups, the ones who just did eyelid hygiene and the ones who also used the lipid supplement, had big improvements in their OSDI scores, their lipid layer thickness, how healthy their meibomian glands were, and even how their eyelids looked.
It's proof that something as simple as cleaning your eyelids properly can really help.
But here's what's interesting. Adding in that lipid supplement didn't seem to make much of a difference.
Yeah, so now the question is, does adding a lipid supplement to eyelid hygiene actually help everyone? Or is it enough to just focus on doing a really good job with the eyelid hygiene itself?
That's a good point. Maybe there are certain patients who would benefit more from the lipid supplement, or maybe we need to figure out exactly when and how to use it in our treatment plans.
Right. It all comes down to figuring out what each patient needs and using the most up-to-date research to guide our decisions.
Okay, so as we wrap up this part of our discussion, what are some of the big picture things that we've seen so far?
Well, I think one thing that's really clear is that MGD is a lot more complex than we might have thought. It's not just one thing, it's a whole range of presentations. And it's affected by so many factors, things like how old the patient is, their overall health, even how their eyelids work.
And we're learning more and more about how inflammation is a big part of MGD. That's leading to research on new therapies that can target specific parts of the inflammatory process.
Exactly. And we can't forget about technology. Meibography, for example, has completely changed how we look at the meibomian glands. It gives us so much information about their structure and function, which helps us decide on the best treatment. And all the new imaging and analysis techniques that are coming out are helping us understand even more.
It's an exciting time to be working in this field. We're moving away from this one-size-fits-all approach to treatment and starting to personalize things, tailoring what we do to each individual patient.
I agree. And with all the research that's going on and all the new therapies being developed, I think we're in a really good position to make huge strides in improving the lives of our patients who have MGD.
This has been a really great discussion, but we're not done yet. We'll be back soon to finish up our deep dive into Professor Sarwar's synopsis and share some final thoughts on where we see the future of MGD treatment headed. And we're back, ready to wrap up our deep dive into Professor Sarwar's synopsis on Meibomian Gland Dysfunction.
Yeah, it's been a really interesting journey, hasn't it? Looking at all this research and getting a sense of where things are going in this field.
It really has.
Yeah.
And for me, one of the big takeaways is that we need this holistic approach to managing MGD. We can't just focus on the glands themselves.
Absolutely. We've got to consider the whole environment of the ocular surface, the patient's overall health, even their lifestyle.
Right, like we saw how diabetes can make MGD worse.
Yeah.
And even something as basic as blinking can impact meibomian gland health.
That facial palsy study was a great example of that, how those muscles and nerves and glands are all connected to keep the ocular surface balanced.
It really highlighted how important it is to do a thorough assessment, not just looking at symptoms, but digging deeper into what might be causing the MGD in the first place.
Yeah, for sure. We need to take a good history, look at what medications they're on, and really understand their daily routines. Things like how much time they spend looking at screens.
Because all of that can contribute to dry eye and MGD. And of course, we need to give our patients the tools to take control of their own care.
Patient education is key. We've got to teach them how to properly clean their eyelids, the benefits of those warm compresses, and how important it is to take breaks from their devices.
And we can't forget about nutrition. Making sure they're eating a balanced diet with plenty of omega-3 fatty acids can really support both tear film and meibomian gland health.
Yeah, it's about helping them build that healthy lipid layer from the inside out. But even though lifestyle changes are important, we've also got to stay on top of all the new technology that's coming out.
Speaking of technology, those liposomal drug delivery systems were pretty amazing. Being able to get medication right to the meibomian glands is a game changer.
That research on the curcumin-loaded liposomes is really exciting, especially for patients who can't tolerate the traditional medications.
It opens up a lot of possibilities.
Mhm.
And on the diagnostic side, meibography has been huge. It's changed how we evaluate meibomian gland structure and function.
It's an essential tool for sure. And with all the new software and analysis techniques that are coming out, we're learning so much more about gland dropout, lipid layer thickness, even what might predict how well a patient will respond to treatment.
It's incredible how technology is helping us understand and manage MGD better. But even with all these advances, we can't forget about the human side of things.
Oh, absolutely. Empathy, communication, patient education, those are just as important as any technology we have.
It's about really listening to our patients, understanding what they're going through, and tailoring our approach to their specific needs.
Because in the end, we're not treating eyes, we're treating people.
Well said. This deep dive has given us a lot to think about when it comes to MGD. Professor Sarwar's synopsis has really provided a window into what's happening now and what the future holds for this field.
It's been a pleasure discussing this research with you, and I hope our listeners are walking away with a better understanding of just how complex, how important, and how exciting the world of MGD management is.
If there's one message we want everyone to take away from this deep dive, it's that MGD is a serious condition, and it deserves our full attention and expertise.
By staying informed, embracing new technologies, and always putting our patients first, we can make a real difference in their lives.
Couldn't have said it better myself. So until next time, keep those minds curious and those eyelids clean.
And may your tear films be forever stable.
This has been The Deep Dive, signing off.